بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. In continuation to the series of Ophthalmology Made Easy lectures, our lecture for today is about the interpretation of perimetry map. We will discuss in simple way the principles of thresholding and the perimetry and the different SIATA strategy. And we will come across different types of perimetry like short automated wave perimetry and the frequency doubling perimetry. And we will go deeper and read the different types of perimetry maps and plots. And I hope by the end of this lecture, you will enjoy and you find it very useful for you in your daily practice. We will start with the first slides. A brief note on the history of perimetry before speaking on the details of this technique. That perimetry and the visual field testing has been used as a clinical ophthalmological diagnostic tool for many years over the last 150 years. And actually, there are a lot of attempt has been made for the assessment of the peripheral visual field many years before this time. But the appearance of the perimetry as it is now practiced has been mainly appearing over the last 150 years. Although they are based on the same principle of detecting a small target superimposed in a uniform background at different locations within the visual field, but there was improvement in the automation that becomes more automated and more effective and more standardized and easy to use and more reliable. This is the advancement that has been happened over the last 150 years. But all these advancement is mainly based on the principle of detecting a luminous target that's moving against a luminous background. And if we want to speak about the prime mover or the main prime force that is used or responsible for the perimetry is Albert, the German scientist that's Albert van Graffy, who has been born in 1828. And he's a young scientist that he has a lot of innovations in this field and in this regard. And he has published an article in the examination of the visual function in amblyopic affection. And by amblyopic affections, he means he published this book at this article at the age of 28. And at that time, the integration or the association of intraocular pressure and the visual field changes and the coming was not integrated. And they were naming glaucoma as amblyopia. Glaucoma, the name is come after that. So he described some visual field changes that happens in the glaucoma, and he has a lot of innovations in the field of ophthalmology. As you know, the Van Graffy sign in thyrotoxicosis and the Van Graffy knife, special blade with the sharp, narrow blade. And also he's the one who invented the iridectomy, and he used it in the treatment of secondary glaucomas due to iridocyclitis. Also, he has a lot of contributions in the field of strabismus and especially in the surgery. And he's the one who suggested the share of the surgery in the other eye to correct one eye. So if there is a large angle sequence in one eye, he can work in the other eye. He's the one who shared this idea. And also he described the hemanopic visual field changes. Also, he has some suggestion in this regard. However, so this is he died over a young age, around 42 years. Lived 42 years, and he's very famous, and especially in Germany. And Van Graffy's clinic in Germany is very famous at that time, and it was a reference point to a lot of doctors and patients to seek his medical advice. Just a few words on important people who contribute to the evolution of perimetry, and they have a large contribution to the advancement in the technology of static automated perimetry. One of them is the Professor Hans Goldmann. In honor of his contribution, the device of perimetry has been named as Goldmann perimetry, which is started as a kinetic perimetry, then changed to static perimetry. So Goldmann perimetry or Professor Goldmann is between 1899 and 1991 is one of the important contributors to the modern perimetry and visual field testing. Another person is the Franz Frankhauser, and that he is the father of the static automated perimetry. Especially, he's invented the octopus perimeter, the famous brand that's the octopus perimeter at the early of 1970. Then after that came the Professor Andreas Hill, the one who is invented the Humphrey field analyzer. He's from Sweden, and he's with others contribute to the advancement in the Humphrey visual field system. And when we speak on the automated perimetry, we shouldn't forget this person. That's Douglas Anderson. He's the famous person that has a large contribution and interpretation and understanding of the automated perimetry, and he has supervised many boxes. And one of the famous box in the static automated perimetry published by him is one of the most popular book in the static automated perimetry. That's from Douglas Anderson. Visual field. The visual field famously is defined as the hell of vision in the sea of darkness. And the visual field is represented in 3 dimensions. The X and Y represented by the spatial orientation of the visual field or the boundaries of the visual field. However, the Z-axis represented by the depth of the visual field. And the depth, by the depth, I mean the sensitivity. So you can see that the most sensitive part of the visual field is the top part, which is the fovea. And there is a depression here due to the blind spot. And the sensitivity decline as you go toward the periphery. So this is the seeing area, and the darkness, that's the sea level, that's the dark area. And there is an inverse relationship between the sensitivity of the retina and the brightness of the stimulus. The more the retina is able to detect a low bright stimulus, indicate its high sensitivity. That's why in the macula or in the fovea, the best sensitivity is there because it is able to detect a very low bright stimulus. The boundaries or the extension of the normal visual field, we have a visual field extend up to 60 degrees superiorly and 60 degrees nasally and 75 degrees inferiorly and 100 degrees temporally. And as I said, that the perimetry is a subjective examination method to assess the visual field, which is called the perimetry. And it is broadly classified into a kinetic perimetry and static perimetry. In the kinetic perimetry, the stimulus is moving from the non-seeing area to the seeing area to plot the boundary of the visual field. And the areas of equal stimuli sensitivity is called as isopters. However, the static perimetry, that we have different stimuli at different locations, and we assess the visual field in 3 dimensions, not only the boundary of the scotoma, but also we can determine the depth of this scotoma. Now, when the patient is sitting in front of the machine starts to determine the threshold sensitivity of his retina. And this made by projecting different light intensities at different locations of the retina, usually in the center, and determine the response of the patient. If the patient can determine at least half of this low dim light intensity, it will determine that level as the threshold. So it projects light of different light intensities. This is of dim light, and this is intense light intensities. A minimum 50% is picked up by the patient response, says yes, I can see this. This is determined. This means that this is the threshold of the retina, and this is the first duty of the machine to determine before start testing the different areas of the retina. We have another test is also called supra-threshold test. This is mainly used in screening programs, and this is more brighter than the threshold test and seen more than 50% of the time. The same thing seen more than 50%. And the infra-threshold is dimmer than the threshold test and seen less than 50% of the time. So this is very important principle we should understand in preparation to interpret the perimetry map. Kinetic perimetry is one variety of the perimetry that's named kinetic perimetry. As I said, that this is assesses the visual field in 2 dimensions, and there is a moving object from the non-seeing area to the seeing area. This determines the boundary of the visual field. It is a 2-dimensional assessment of the visual function, unlike the static perimetry. So we speak only in x and y axis and no z axis in kinetic perimetry. We come to the static automated perimetry. This method is static. In static automated perimetry, we use it to quantify the retinal sensitivity of the field of vision of the patients, and we determine if there is any deviation of this sensitivity from the normal. So static automated perimetry uses quantify the amount as well as quantitative and qualitative assessment of the field of vision. Quantitative in terms of numbers, that we give numbers for each point in the retina and the corresponding retinal sensitivity. And a qualitative assessment, it gives a general information in the overall sensitivity of the retina, as we can see, and we will discuss later in the screening tests. In the screening tests, we didn't give a quantifying numbers or giving any numbers. We just give qualitative impression about the field of vision. That impression can be in the form of localized defects in the visual field, as you can see here, or generalized depression in the visual field. So this is the main aim of the static automated perimetry. And there is an inverse relationship between the intensity of the light and the retinal sensitivity. The more the eye is able to detect low sensitive or less bright light source, it is indicated that it is more sensitive. So this should be very clear before we start interpreting the map of static automated perimetry. Static automated perimetry is a standardized procedure. By standardized procedure, we mean that the parameters used in the static perimetry is standardized in terms of the stimulus size and locations and the background illuminations for different strategies based on the strategy that you are using. So in static perimetry, there is a static or there is a constant background illuminations that's in Humphrey around 31.5 apostips, and in Octopus it differs a little bit than the Humphrey. And also we have a constant stimulus size, usually size 3, Goldman size. Of course, the size will be changed according to the strategy that you are using. However, we are using a variable stimulus intensities in the same test and various variable locations in the same test. But the main principle, it depends on shining a bright stimulus that is in a bright background, and the intensity of the stimulus is variable according to the stimulus intensity. And the threshold stimulus is defined as the dimmest stimulus or dimmest brightness of the stimulus that the patient can see 50% of the time. And in reality, the standard automated perimetry exactly like when we see the stars on the sky at the night. Now this is the stars represent the stimulus, and the background illumination is the sky. So in the daytime, because of high illumination and high brightness of the sky, so you will not see the stars. However, at night, because of this differential illumination and difference in the illumination between the stars and the background, at night you see them very clearly. So this is the principles of static automated perimetry, and we used constant background illumination with constant stimulus size. However, we use variable stimulus illumination and variable locations. As I said, that the static perimetry is a standardized way of assessing the visual function. It is unlike the OCT, which is a structural assessment of the retinal functions. The static perimetry assesses the function of the retina, and we have standard parameters. One of them is the size of the stimulus. We have different sizes from size 0 to size 5 Goldman sizes, and this is the corresponding areas in square millimeters. The most commonly fixed and most commonly size we use is the size 3 Goldman size in most the standard perimetry. We sometimes use Goldman size 5, especially in 10-2 perimeter or in advanced glaucoma. However, the most common size we use is the size 3 Goldman size. The second important variable in the static automated perimetry after the stimulus size is the stimulus intensity. And the stimulus intensity is measured by what's called aposteps. And the stimulus intensity of the maximum stimulus intensity in the Humphrey automated perimetry is around 10,000 aposteps. And by certain logarithmic conversion or logarithmic attenuation, it attenuates this brightness by special filters so that we achieve different stimulus intensities based on this logarithmic attenuation. For example, one logarithmic attenuation will receive 10 decibel attenuation of the light stimulus. So by variation of this filters, there will be variations in the light stimulus intensity. And similarly, for example, in octopus, the maximum light intensity or stimulus intensity is around 4,000 aposteps. So we will see in the next slide how the logarithmic attenuation of the light intensity taking place and its corresponding decibel filters. To understand the conversion from the aposteps to the decibel system, as you know, the unit used for the measurement of the intensity of the stimulus is the aposteps. That's a measure of the luminance or the intensity of the light. That's the aposteps. Now, they assume a logarithmic conversion, logarithmic attenuation of this stimulus. The maximum stimulus in the Humphrey system is 10,000 aposteps. However, in the octopus system, it's around 4,000 aposteps. Now, this stimulus is underwent logarithmic attenuation by if it undergoes one logarithmic attenuation, its intensity will be equal to 10 decibels. And if two logarithmic attenuation, its intensity will equal to 20 decibels. And this system is inversely related to the retinal sensitivity. That is to say, if we say that the stimulus has a 40 decibel, this indicates that this stimulus is very, very dim because it undergoes very high attenuation. dB, to understand this, understand that dB stands for depressed by. So they use special filters in front of the light to depress its intensity, depressed by. So if a very high stimulus like this is depressed by 40 decibels, so you will receive a very dim light. However, if we say that the retinal sensitivity is 40 decibel, this indicates a very high retinal sensitivity that it is able to detect this very dim stimulus. So there is an inverse relationship between the light intensity and the retinal sensitivity, and we assume this logarithmic conversion of the decibel system to understand the relationship between the light intensity and the retinal sensitivity. As you can see here also, the light intensity is increased gradually and the level 32 this is the usual and the normal intensity of the fovea of the normal young person. This is the normal intensity. For octopus system, the maximum stimulus intensity is 4,000 obsteps. So we should understand clearly what's meant by the basic units that used in static perimetry. That's the apostable and the decibel. So the apostable is a measure of the luminance of the light intensity, and the maximum intensity in Humphrey perimetry is around 10,000 apostaples. However, in octopus around 4,000 apostaples. And the decibel is a measure of the attenuation of the light. Remember, decibel stands for depressed by. So the light is attenuated using a neutral density filter. The higher the decibel attenuation means greater attenuation, and accordingly the light will be more dimmer. So if you attenuate the light more, it will be more dimmer. And when we have a 0 decibel, it means there is no any attenuation of the light. So your light will be at maximum brightness, that is at 10,000 decibel. So when you find in the perimetry map that point has a 0 decibel, it means that at this point the patient can see the light at maximum brightness even without any attenuation of the light stimulus. However, if you find this mark that's less than 0 decibel, this indicates that the patient is not able to see the stimulus even it is at maximum intensity or without any attenuation. And the threshold stands for the dimmest stimulus, that's most attenuated or highest decibel attenuation. That's the dimmest stimulus that can be seen 50% of the times when presented to the patient. That's the threshold. So by this, it is clear now what's the meaning of apostable and what's the meaning of the decibel. Now, decibel is used to express the retinal sensitivity. The more the decibel, the more the sensitive is the retina, and the apostable refers to the intensity of the light stimulus. The more the apostable, the more the brightness. Now we will come to the main aim of this lecture, and the main objective is to study the different test strategies. We have the standard threshold strategy and the theta standard, theta fast, theta faster, and also we have the octopus strategies like tendency oriented perimetry and the dynamic strategy. Also, we will study the different test patterns. So we have strategy and pattern. The patterns refers to the matrix that's used during the visual field assessment. That's 30-1, 30-2, 24-2, 24-2C, 10-2, and also in the octopus like G map and the M map for the macula and so on. Also, we will go through step-by-step interpretation of the different zones of the perimetry map, starting from the demographic data of the patient to the grayscale and all the probability statistical tests applied to the results. And finally, we'll come to the guided progression analysis and also the cluster analysis and the polar analysis on octopus that assess the serial visual fields of the patient. So let's start with the first, that is the different test strategies, standard threshold strategy and theta strategy. Now, as I mentioned before, that for a best test for the retinal sensitivity, we need a test. We need to test all the retinal points and all the retinal location, which is this is impractical in reality, because if you want to test the whole retina, you need at least 4,800 test locations if they are 2 degrees apart with a stimulus size of 3. And for a stimulus with 6 degrees the spacing, you need 550 retinal locations. And for 10 degrees spacing between stimuli, you need at least 190-degree locations to be tested for stimulus size 3. And this is very impractical and time consuming, and the patient will not be compliant with you. So, by strategy, we mean the special techniques adopted by the machine to minimize the test duration and not compromising the test quality. That we have good test quality according to the clinical condition of the patient and the need of the clinician, and also shorten the test duration so that make the patient compliant with your test. So this is named as a strategy. So the strategy can be a quantitative strategy or qualitative strategy. Quantitative strategy, that's the thresholding technique, which is the best method to exactly determine the threshold sensitivity of that point of the retina. However, the qualitative strategy is not as precise as the quantitative strategy, that's the thresholding, but it gives you a quick screening information about the shape of the visual field, and it gives it mainly examines the absolute areas of defect, and it is very fast. So we need to do a quick screening test first to determine if there is any abnormality or not. And if there is abnormality in the screening test, at that time we can proceed with the quantitative method, that is the thresholding technique. A brief note in the different strategies that is used by the two most common available perimetry in the market, that's Humphrey and Octopus perimetry. Of course, there is plenty of different brands of perimetry with different strategies are used, but I think this is two of the most common perimetry available in the market. And the different strategies used, like the full threshold strategy and the recently developed the CETA strategy, which can be subdivided to CETA standard, CETA fast, and CETA faster, and also the octopus strategies, that's the normal thresholding strategy, and the dynamic, and the top strategy, that's the tendency oriented perimetry strategy. And we will go briefly and deeply a little bit to understand the difference between the thresholding and CETA standard and CETA fast and CETA faster, so that you will be able to choose the strategy that you need that suits your requirement. For example, when you are looking for a screening test, you might go for CETA faster, or you go for top strategy. When you want to go for thresholding strategy, if your patient is compliant with you and he can withstand long time, you can use the threshold strategy or the CETA standard that take long time. If your patient is not tolerant to the stay for long time in the machine and you want to short the test, you can go for CETA fast, or you can go for the dynamic strategy, and so on. So you have to know the difference between the different strategies, and you choose what strategy that suits your needs and suits your patients. And also you should understand about the different patterns, and these patterns are chosen and predetermined in the machines, so that it for needed or applied for each disease that you want to check for, the 24-2, the 24-2C, and the 10-2, and so on. So in the next slides, we will go through the difference between these strategies before we will go to the understanding the perimetry map. So I think that by understanding these strategies, it is important. After that, we will go to interpret the perimetry map. Now, what are the different strategies that are used in the automated perimetry? One of the most common strategies is the staircase based. That's the staircase or the bracketing strategy, which is the full threshold strategy or the dynamic strategy. In Humphrey automated perimetry, it uses the strategy of 4-2-2. That is, we project a stimulus. Then if the patient is seeing it, decrease it by the brightness by 4 decibel. Then if the patient not see the stimulus, increase the brightness by 2 decibel, and this to another 2 decibel, so that it takes the threshold point in between these two points. This is called 4-2-2 strategy or full threshold strategy. In Octopus, it is called dynamic strategy. It assumes the 4-2-1 strategy. That's
after the initial stimulus is seen or not seen, it is increased or decreased by 4 decibel, and according to the response of the patients, increase or decrease another 2 decibel, then another 1 decibel, so that nearly find out the threshold point or the retinal sensitivity at that point. Another strategy is the complex statistical method, which is called the Poisson posterior probability functions, which is Poisson's based. It is the ZEST or the Quest, and the last one is a combination of both the staircase strategy as well as the Poisson strategy. Now, this Poisson strategy, you should remember this name because the examiner will ask you what's the strategy used in the automated perimetry. You should be able to say the bracketing strategy and the Poisson posterior probability functions. Now, this is the new combination of both, is giving the switch interactive threshold algorithm, that is the CETA. And then now CETA is subdivided into CETA standard, CETA fast, and CETA faster. So this is all the types of the strategies used in perimetry. In this slide, I will explain in details how the exact method of full thresholding or staircase strategy is performed. Let's choose any point here. For example, this one, noted 1. This is the 30-2 pattern of the visual field, in which the different spots of the visual field is plotted here. And this diagram shows the intensity of the light, the initial stimulus chosen at 25 decibel. So when we throw this stimulus to the patient denies to see this response. He says no. So we will increase the intensity of the stimulus by decreasing the decibel. When we decrease, there is inverse relationship. When we decrease the decibel, the intensity of the light will be increased. So we will keep on decreasing by 4 decibel till the patient see the first response. So here he is not seeing, here is not seeing, here he is not seeing. Here the patient sees the response. So this is called a reversal of the response. Once there is a reversal of the response, we will now increase the by 2 decibel, so that they decrease the intensity of the light to determine the dimmest stimulus that can be seen be seen by the patient. So now here the patient still seeing the response, so we will increase another 2 decibel. So here he denied to see the response. So once there is a reversal of the response, here it is called the reversal of the response, we will increase the intensity. So this one will be the last point that is representing the threshold of this point. Okay, so this is the last seen point. Here is the threshold of this patient, and usually the machine will do this for the initial 4 points. For example, this is the 4 points will be tested by this double staircase strategy from the beginning, from this 25 decibel. However, when we go to the area number 2 here, the another points, it will start from the last decibel seen by this number 1. For example, the sensitivity here determined in the area number 1 by 12 decibel. For example, in this example, around 12 decibel. So in this spot, it will not start from 25. It will start from 12 decibel and do the same strategy here till determine its sensitivity. Similarly, if we choose area number 3 here, it will start from where the last response received by spot 2. This is called the growth strategy or growth pattern or growth strategy. This is the full threshold strategy, that is 4-2-2, which is the principles of the full thresholding, which is seen in Humphrey perimeter. Here I will explain in detail what the machine do in the standard threshold strategy, the standard threshold strategy. Now, suppose the patient receive a stimulus falling in this area of about 24 decibel intensity, and the patient can see this stimulus. Now, the machine will try to decrease the intensity of this stimulus by increasing the filters in front of the stimulus, that is increased by 4 decibel. So the next stimulus will be around 28 decibel to decrease its stimulus. And the initial stimulus was 0.2 seconds duration, and the reaction time of the patient up to 1.8 seconds. So the initial stimulus is 24 decibels, and we add another 4 decibel filter in front of the stimulus, so that attenuated by 28 decibel to decrease its intensity. And now still the patient is able to see this stimulus. So what they will do, the machine repeat the same steps again, so that see the response of the patient. Now the patient is not able to see this stimulus. At this point, there is a reversal of the response, so the machine will increase the intensity a little bit by decreasing the filters in front of the eye by 2 steps, so that is 30 decibel. And since the patient is not able to see this stimulus, so it decreases another more 2 decibel. So now the patient is seeing this stimulus. So this is the final point. This is the threshold value of that point that is tested by the standard threshold technique. And this technique is called the double stare strategy, because the line between the seeing and non-seeing area is crossed twice, as you can see here. So it is crossed twice. As you can see, this is a long procedure and long process done mainly for the 4 cardinal initial points of the adjacent to the fixation, and the extra 6 points that's done after these 4 points. That's why the standard strategy takes long time but very accurate in assessing the sensitivity of the retinal points. The same thing here for the double stare strategy. This is another example that the initial stimulus is exposed for 0.2 seconds, and the response time is 1.8 seconds. So now the patient seeing this stimulus, but the machine, when decreases the intensity of the light by adding another 4 decibel attenuation, now the patient is not seeing this stimulus. So it will start increasing the intensity by adding another 2 decibels. So the patient is seeing this one. So this is the threshold value of the retinal sensitivity at that area. This is the principle of double stare strategy. I will give another example. Now, if the initial stimulus is not seen, for example, now we throw a stimulus, the machine throws a stimulus of 32 decibel intensity, and the patient was not seeing this stimulus. So logically, the machine should increase the intensity of this stimulus by decreasing another 4 decibel from this value. So the next stimulus will be 28 decibels. Now the patient is seeing this stimulus, so it start adjusting and modulating by decrease it by 2 decibel. Now the patient is seeing, now another 2 decibel is removed, so the patient is not seeing this stimulus, so it will take this stimulus as the threshold value. This is the principles of double stare bracketing strategy. Now in the threshold assessment of the retina, when, as I said, the machine, once the patient sits in front of the machine, it start assessing the threshold of the retina of the patient. It does that by testing the initial 4 points adjacent to the midline and the horizontal midlines. These 4 points within the central 9 degrees from the fixation. And by the double stare or bracketing strategy, as I explained earlier, it tests these 4 points twice to determine the exact threshold of that patient. Then it tests another randomly another 6 points again, and this is very important to determine the average threshold of the rest of the retina, as well as determine the variation of the test-to-test variability, the fluctuation and the test fluctuation. By repeating the test twice, we determine the test fluctuation or short-term fluctuation. Should be mentioned here that the stimulus duration is about 0.85 seconds, and there is an average response time waiting for the patients, so that there is no temporal summation for the stimulus. There is a specific duration of the stimulus, and there is a specific time delay to wait for the response of the patient. If the response delayed more than the accepted duration, that is 0.85 seconds, this will be regarded as negative, and this will be omitted. So this is very important to avoid the temporal summation of the stimulus. Now let's speak about the different strategies available for assessing the retinal sensitivity. We have spoken in details about the standard threshold technique that I explained early by the bracketing the strategy. And as you can see that that technique is very time consuming and it extends more than 20 minutes for examination. And as you know that the compliance of the patient in this test is very important as this test is a subjective test. And they notice that with time patients lose compliance and start having fatigue and a lot of false positive and false negative will occurs in the test. So they start thinking how to modify and modulate the test so that we have a better or the same result with a shorter time. For this, the full threshold strategy I have explained earlier. There is another strategy which is called the CETA standard. That CETA stands for the Swedish Interactive Thresholding Algorithm, which can be subdivided into CETA standard and CETA fast, and the newer one is the CETA faster. This technique is more faster, between 12 to 13 minutes for the standard one, and accordingly the other one the time will be reduced. It gives a good result, not comparable as precise as full threshold, but it is reliable to some extent and it is useful in the time that's short time. Now I have a question just to revise our knowledge and I make sure that we understand what we are talking about. Now, my question is that if the initial stimulus when we start the perimetry was 28 decibels, then the value of the next stimulus is what? Is it 24 decibel or 28 decibel or 26 or 30 decibel? Now, if you look to this question, there is one thing is missing. Now, if this the initial stimulus is 28 decibel, now what's the response of the patient? Now, if the patient see this stimulus, so we will need to decrease the intensity of the light by adding more decibels. However, if the initial stimulus is not seen by the patient, so we want to increase the brightness by decreasing the decibels. Okay, so let us see now. As you can see here, the initial stimulus falls in the non-seeing area. So the patient is not seeing this stimulus. So by logic, we have to decrease the intensity of the, we have to decrease the decibel to increase the intensity of the light. So increase the intensity of the light. So if this is 28, I expect this one should be 24. Let's see. Yes, so if the initial stimulus is 28 decibel and the patient is not seeing, so we have to decrease the decibel, that's the burst by, as I said before, so that it can be seen in this area. It should fall in 24 area. The reverse, if the initial stimulus is falling in the seeing area, so at that time we have to increase more the decibel to bring him to the non-seeing area. I hope this is clear. After we have spoken about the standard thresholding strategy, which is time-consuming process, they came to create a new strategy. That's the CETA strategy, that stands for Swedish Interactive Thresholding Algorithm. This strategy is more shorter than the standard thresholding strategy and with a good accuracy and reproducibility. And it instead of using the staircase strategy method, it uses a logical forecasting and complex statistical softwares to predict the adjacent sensitivity of the adjacent areas. And as I said, that it is dependent on the four main cardinal points, and it doesn't test the extra 6 retinal points. And CETA standard 50% achieves 50% reduction in the time to the full threshold strategy, and we have a faster than the CETA standard, that is CETA fast, additional 30% reduction in the time as compared to the CETA standard, but it is less accurate as we omit some points and we decrease the repeating of the points, the testing of the points, so this reduce the accuracy of the test. And recently now very fast the strategy is the CETA faster, which is take about 2 minutes per eye, and this is mainly for screening purpose rather than exact diagnosis. In this slide, I will demonstrate to you how the CETA strategy do and what's the machine do using the CETA strategy as compared to the standard thresholding technique. And this is the confidence interval that the machine create based on the initial 4 cardinal points. Based on the 4 cardinal points, it assumes a particular confidence interval that any response within this area is regarded as a threshold value. And as I said, that the CETA strategy, there is no extra 6 points tested twice, only the initial 4 cardinal points. So if the initial stimulus falls in this area, which is the non-seeing area with a 28 decibel intensity, so the machine will increase the intensity of the stimulus so that it will fall in this area, and then it will decrease by 2 decibel so that the stimulus falls in this area. Now, in this area, it is regarded as threshold value. Now you can see that the line between the seeing area and non-seeing area is not crossed twice, only once. So by this way, we reduce the time of the machine to test the sensitivity of the retina. This is another example. The same thing, the stimulus from the non-seeing area to the seeing area falls directly within the confidence interval. So we take this point as the sensitivity of the retina. As I said, that the CETA standard or CETA standard takes in consideration the age of the patient and the normative data of the patient, and the information is extracted from the initial cardinal points that we examined, and there is no extra 6 points, and also it predicts from the adjacent points. It can extrapolate the sensitivity based on this complex statistical software or statistical processing that's using the Python posterior probability function. In CETA fast, same like CETA standard. However, the acceptance interval for the stimulus has been increased. Now, if this line represents the acceptance interval for the CETA standard, and this interval is represent the acceptance interval for the CETA fast. So if the patient or the stimulus falls in this area, if we follow the CETA standard, we'll regard that this stimulus is beyond the acceptance area. But in CETA standard and CETA fast, it is within the acceptance area. So the machine will accept this as the threshold value. That's why it is very fast in time and kept mainly for patients who cannot withstand sitting for a long time with poor attention. Now we will go in details and see what CETA fast do. In this slide, I will show quickly the difference between CETA standard and CETA fast. As I mentioned earlier, that is the main difference is the confidence interval. This is in the yellow line. This is the confidence interval for the CETA standard, and this one extended to the CETA fast. That's why it has a wider range of acceptance. Now, if we have a target stimulus here, and the patient is not seeing it, so the machine will decrease the intensity by 4 decibel, and now it falls in the seeing area but outside the confidence interval. Now it decreased by 2 decibel, now it falls in this area, but even it is outside this area, which is for CETA standard, it is accepted by CETA fast as threshold value. Similarly here, if the stimulus directly goes to this area, it will be accepted as threshold value. So this is the main difference between CETA standard and CETA fast. Now, after we understood the mechanism of full threshold testing or the staircase strategy has been done, and full staircase strategy, full threshold strategy is a long procedure, takes long time, and now no more use it, and most of the machines, they adopt the new strategy, that is the CETA standard or the CETA fast and the CETA faster strategies. Now for the CETA standard, it assumes a combination of both the complex statistical psychophysical tests, that's the Python posterior probability function, along with the double staircase strategy. But why the CETA strategy is more shorter in time as compared to the full threshold? There is some explanation for this. That's the number one. It assumes the Python approach, which utilizes a psychophysical test that it can predict the sensitivity of the adjacent points of the retina, so that it saves a lot of time in the test time. Another important point that in the CETA standard, it eliminates the false positive catch trials. Now, what's the meaning of false positive catch trials? I will explain this in this graph, and let's see the third point. Why the CETA standard is short time is by using adaptive interstimulus interval. Now, if we come to this chart, for example, this is the stimulus that we project to the patient of 200 millisecond duration, and then we wait for another 1000 milliseconds. Then another stimulus will come with duration 20 milliseconds. Then we will wait for another 1000, and so on. This is the machine. And this is the response of the patient. For example, the patient responds in the first 800 milliseconds, it gives the response. The second one also, after 800 milliseconds, gives the response, and third like this. Now, the machine will understand and interpret that the usual response of this patient is 800 milliseconds. So it will, this is the reaction time of the patient. So it will adjust the time, the interstimulus time interval, adjust it so that the next stimulus will come at 800 milliseconds. So the patient, by this way, we will save some time for the procedures. After predicting the reaction time of the patient from the initial stimuli, the interstimulus interval is adjusted and altered according to the reaction time of the patient. Now, for this false positive catch trials, you know that the machine will, the false positive means what? The false positive, that there is no light presented to the patients, and the patient, only the sound is presented to the patients, and the patient will press that as if he has seen the light. That's the false positive. That's usually seen in the full thresholding technique. Now, in the CETA standard, instead of this way, it according to the reaction time of the patients. So if there is any stimulus less than 50 milliseconds, the initial stimulus, the response, if there is a stimulus here and the patient respond, for example here, if the stimulus is here and the patient respond within the first 50 milliseconds, and the machine knows that the response of the patient is 800 milliseconds, so it will regard that this stimulus is a false positive. So this is by this way, it eliminates the false positive catch trials, and it depends on the reaction time of the patients. If there is response within the first 50 milliseconds, that is before the stimulus has processed by the patient, so this indicates that it is false positive. Now, in the new strategies that is emerging after CETA standard, that is the CETA fast and CETA faster, especially in CETA faster, it is more shorter in the time because it eliminates even the false negative and the blind spot catch trials. Even the blind spot catch trials, it eliminates it, and also it eliminates the false negative catch trials, and it depends only in the fixation of the eye via gaze tracking. So there is no more tests for the blind spots to determine the fixation, and it depends on the gaze tracking. By this way, it is shortened the time too much. Now, the question that arises, that's, yeah, although the CETA faster has improved the time needed for the patient to do the testing of his visual function, but the reliability of the test becomes questionable as we eliminate these catch trials that might be affecting the result of the patient. As you know, false positive and false negative are very important to interpret in view of the retinal sensitivity of the patients. If there is too much false positive result, this will change the mean deviation and the pattern deviation, and then the visual index will be totally changed. So we'll discuss this later. But now in this slide, just only I want to show why theta standard is more shorter in time as compared to the full threshold strategy, that is the double staircase strategy, because of these three parameters. It assumes along with the double staircase strategy, the Poisson posterior probability function, and also it eliminates the false positive catch trials. Now, this false positive is eliminated in the theta standard only, but in the theta faster, it eliminates both the false positive catch trials, false negative catch trials, along with the fixation catch trial for the blind spot, and only it keeps the gaze tracking. The last parameter why it is short in time, that it has an adaptive interstimulus interval, as I explained here. The machine will understand the reaction time of the patient and it will adjust the interstimulus interval accordingly. So in summary and in comparison between the full threshold strategy and the theta standard strategy and the theta fast strategy, here in the full threshold strategy, we do the double stair strategy for the 4 cardinal points and another extra 6 points. And we repeat the test more than once to determine the inter-test fluctuation and test variability. However, in the theta standard, we depends mainly in the 4 cardinal points without the extra 6 points. And we have a confidence interval or acceptance interval as presumed by the statistical method presumed by the machine. In the theta fast, the confidence or acceptance interval is wider than the theta fast, and it is exactly the same as theta fast. Among the new family of theta fast strategy is the emerging of the theta faster, which has been emerged and available in the Humphrey field analyzer type 3. And this theta faster strategy shortens the time of the examination by around 30% of the theta fast and around 53% by theta standard. The reason why, because this is the table showing the difference between the theta fast and theta faster. For example, the initial stimulus in theta fast is 25 decibel, and we will start doing the staircase strategy then twice for the initial 4 cardinal points. However, in the theta faster, the initial stimulus is based on the age matched, and the testing for the first 4 cardinal points is done only once. Another thing, the blind spot catch trial and the false negative catch trial that's done in the theta fast is not available in the theta faster. That's why the time around 2 to 3 minutes for the theta fast is done. Now the question is it reliable as theta standard? Of course, it will not be as reliable as theta standard. However, there are many papers and many arguments about this regard, when to use theta fast and when used to use theta standard. And among this new family, they incorporate the 24-2C. Now we will speak about the pattern of the visual field printout in the next slides. But this is a new family that is emerging. That's the 24-2C theta faster. You will find this only in Humphrey visual field type 3. Now, when we speak about the pattern of visual field, we'll speak about this new entity of perimetry map. That's the 24-2C. So by this, we finish the different strategies. That's the theta standard, theta fast, and theta fasters. And we will speak about the other strategies, especially in Octopus, like the tendency-oriented perimetry and the dynamic strategy in brief a few words. Then we will start speaking about the pattern of perimetry. Here I will speak about a new addition to the family of theta strategy is the theta faster 24-2C. Now, as you know that in the 24-2, it measures the central 24 degrees, and there are around 12 points in the central 10 degrees, and around 4 points only in the central 8 degrees. And in the 20 in the 10-2, we have 68 points in the central 10 degrees. 68 points in the central 10 degrees. So what they do, they incorporate, and this makes the 24-2 is less sensitive in picking up early glaucomatous changes, especially in the central area of the macula, as 10-2. So what they do, they modify the pattern of 24-2. So they add another extra 10 points in the central 10 degree. So instead of we have 4 in the central 8 degrees and 12 point in the central 10, they add another 10 degrees. So a total 22 points will be in the central 10 degrees. And these points are not placed haphazardly. They distribute it according to the damage in the nerve fiber layer, like this. So this is the 24-2C pattern. So you can see this is the 10 points pointed in the yellow color. That's added the 3 in the superior temporal quadrant, and another 3 in the inferior nasal quadrant, and another 2 in the superior nasal and inferior temporal quadrants. So a total extra 10 degrees, and they have a shape of C pattern. And why this C? Because it corresponds to the nerve fiber layers, the damage that can happen in these areas. This pattern is newly emerging. It is called 24-2C. So this is the final grid of the CETA fast 24-2C. As you can see, find the distribution of the spots has been added here that correspond to the distribution of the arcuate fibers of the nerve fibers. And this test has 20% faster than the CETA fast 24-2 and only 30 seconds longer than the CETA fast 24-2. So it is a little bit by 30 seconds only longer than 24-2. Okay, so even with the addition of these 10 points, there is no significant increase in the fast in the test time. There are some limitations of the CETA strategy. That the CETA strategy doesn't measure the short-term fluctuation. As I said, that it doesn't retest the 6 points apart from the 4 cardinal points, and that points are important for the test fluctuation. So short-term fluctuation is not measured. Also, the corrected pattern standard deviation, we will come across this later on, which is dependent on the short-term fluctuation. Another thing that's the CETA strategy is not available for macular and nasal step programs, and its advantage only that is it's short time, so it should be used only for old patients, especially the CETA faster and I mean the CETA faster should be used for all patients because it is very fast, because less reliable than CETA standard. So we keep CETA standard for any patients, and we keep CETA fast for all patients who cannot withstand long duration of the exam, because the CETA fast is less reliable and less sensitive than CETA standard. Now, I will say a few words about the different strategies that's used in the octopus perimetry. The previous strategies that we have spoken are mainly used in the Humphrey perimetry. That's the full threshold strategy and the CETA strategy. Either CETA standard, CETA fast, CETA faster, all are used in Humphrey. However, in the octopus perimetry, it uses the same full threshold strategy, but in this differs than the Humphrey, it is a 4-2-1 strategy. That is, after the initial stimulus, we upgrade or downgrade the intensity of the stimulus by 4 decibels. Then, after the first reversal response, by another 2 decibels. Then, after the second reversal response, by 1 decibel. Unlike in Humphrey, it is 4-2-2, 4-2-2. The other strategy is the dynamic strategy, which is correspond to the CETA standard, and the other is the tendency-oriented perimetry strategy, which is correspond to the CETA fast and the screening strategy. We will give few words about the dynamic strategy and the tendency-oriented perimetry. Of course, the idea of these different strategies is that you are in a race between the time of the exam, that should be short time, but not in the compromise of the quality of the result. So always the precision comes at the cost of the time. The longer the time, the better the precision. But some people, they need short time on the expense of the precision. For example, if you can see here, we reach to the same result with determining the sensitivity of 32 decibels. We're using, for example, here up to 32 times stimulus per location. So we stimulate the location 32 times. However, in this one, the 16 times we stimulate, and this one 8 times. The one location is examined 8 times. All they give the same result, but the time is different in these three strategies.
I will say a few words about the dynamic strategy that's using in Octopus. This is a useful and fast strategy comparable to the CETA standard in Humphrey perimetry. Dynamic strategy is used in Octopus. It is useful, reliable, and short duration between 6 to 8 minutes. And it's briefly the same, it follows the same principle of the normal threshold strategy. However, the border for threshold sensitivity is crossed only once instead of twice, and it is mainly depends on the principle that the initial stimulus projected to the central area with high sensitivity, and when the initial stimulus is seen by the patients, the next successive stimuli will be decreased in short, small intervals, that is small decibel steps between 1 to 2 decibels. However, in the areas of the decreased retinal sensitivity, the steps of the next successive stimuli will be in large decibels between 6 to 10 decibels. So there will be fluctuation in the intensity or of the stimuli and the steps of reduction or increment in the successive stimuli based on the initial response of the patient. By this, the examination time will be shortened too much. Like in this example, for example, this patient is thrown the light in this area which is not seen, so there will be stepping of the next stimuli by 4 decibels, either it is in the non-seeing area or in the seeing area, till the threshold is achieved in this area. And if so, it take in consideration the sensitivity of the adjacent points, so that by this way it can predict the sensitivity and shorten the time of the test examination by a long duration, so that it gives a more reliable and short test examination. It is comparable to the CETA standard. The tendency-oriented perimetry strategy also is adopted by Octopus Perimeter, is another fast strategy. It is compared to the CETA fast, and it is in a brief based on the principle that we test one point and determine its threshold sensitivity, and then we test the adjacent 4 points. And instead of asking this point 4 or 6 times to determine the threshold sensitivity, we will adjust the threshold sensitivity of this point according to the response given from each point. For example, if you find the threshold sensitivity here is high, it is regarded as high, for example, 20, 30 or 35 decibel, then we will measure the sensitivity of this point. If we find it low, below than this, so we will adjust and decrease the sensitivity of this point. And then when we measure this point, if we find it high, we will increase again this point. So the idea that we adjust the tendency of this and the sensitivity of this point according to the adjacent 4 points, and even this point is adjusted according to the adjacent 4 points, and so forth, like in this grid.
Each point is measured and adjusted according to the sensitivity of the adjacent points and accordingly increased or decreased. So at the end of the perimeter, a precise and nearly very accurate result of the sensitivity of all of the points of the retina. This is called the top strategy or tendency-oriented perimetry strategy. This is seen in octopus perimetry, and the equivalent strategy in Humphrey perimetry is the theta fast. Now, after understanding the principles of the standard automated perimetry and the different strategies are used, when we decide to take a patient to the test or to the machine, we have to identify these three important points. Which strategy should I use? The full threshold strategy or SIATA strategy or SIATA fast? And I have to determine the program that I want to use. Is it 30-2 or 24-2 or 10-2 or macular and so forth. And the third point is what type of perimetry am I going to use? Is it white and white perimetry? That is the standard, or also named as achromatic perimetry, or the swab that's blue and yellow perimetry. So this is very important to be determined before you send your patient to the perimetry room or to the perimetrist to do the perimetry. You should identify for him the strategy you need and the test you need and the type of the perimeter that you want to do. Here, just I want to remind you where we have reached in this session. We finished the different test strategies, like the theta strategy, theta fast, and theta faster, and some strategies that is in octopus perimetry, like tendency-oriented perimetry, and the dynamic strategy. Now we will go to the next session that's the different test patterns done in the perimetry, either 30-1, 30-2, 24-2, and also some of the test patterns that's done in octopus, like the G pattern and the M pattern. Now, the idea of constructing and choosing the right test pattern for your patient comes from the fact that for an ideal visual field, we have to test all the retinal points. But this is in practical is not a practical way of assessing the visual functions, because you need at least 4,800 test points for the retina if these points are 2 degrees apart and spacing. And if they are 6 degrees apart, you need around 550 spots to be tested. And if you have 10 degrees spacing, you need at least 190 degrees points to be tested. And this is make the patient uncomfortable, and hence it will be reflected back on the result, and the result will be unreliable. That's why we concentrate on special test patterns that service our needs and concentrate on the area of focus that we want to assess the visual function for that area. Now the question that arises, why the central 30 degrees? Now you will notice that in the recent machine, most of the companies and the people who are interested in the visual field are concentrating in the central visual field, and all the machines are predetermined as to measure the central 30 degree. Of course, if you want to measure the temporal area or any other area beyond the 30 degrees, you can do it. However, the most of the recent machines are mainly concentrated on the central 30 degree, because practically that most of the pathology that's involving the optic nerve, they are associated with visual field changes in the central 30 degree. What you need is just to know what test you are going to use and what strategy you are going to use. So don't be bothered of testing the areas beyond this range unless needed for very, very special cases. The other reason is that the central 30 degree is representing 66% of the ganglion cells, and it represents 83% of the visual cortex. So for any medical necessities, it is the central 30 degree that you are should concentrating on. Now, as far as the grid
of the pattern of the perimetry, you should notice the difference between Humphrey perimetry. It takes the shape of a grid, and you can find it like this square, like square picture. However, in the octopus perimetry, it is a radial pattern. It is a radial pattern, so it have this appearance. So just by looking to the map, you can know that this is an octopus or this is an Humphrey perimetry. And the different patterns that is in octopus, like the G2, the M2, and LVC, and this is the different patterns in Humphrey. Will go through each one of them. This is example of the different available test pattern that is practically available. The 30-2 central visual field. Previously it was 30-1, and 24-2 central visual field. Previously was 24-1 and 10-2. And also the macular program and the nasal step. This is usually seen in Humphrey visual field, and they recently added the 24-2C. The G pattern for glaucoma prediction and also the M pattern are seen or are done in the octopus visual field. This is the most common different patterns that are used. We will go through each one of them a few words. This is example of the test pattern that's 30-2 central visual field. Now the figure 30 is obvious that 30 indicate the central 30 degree from point of fixation. But what's the meaning of the -2? Now previously they were using a 30-1, for example, like this one. 30-1 in which all the test points, they are exactly in the midline. The test point falling in the vertical or horizontal midline. So the distance between two test points is around 6 degrees. And also, if there is any defect or any problem, we cannot determine whether it is belong to the right side or left side of the retina. So they exchange it with the 30-2, in which the test points are straddling the vertical midline, like this one. This one is 30-2. You can see clearly here the test points are straddling the vertical and horizontal midlines. So the distance between the test points and the vertical midline is 3 degrees instead of 6 degrees. So if any pathology in this area and belong to this quadrant, and if there is any pathology in this area belong to this quadrant. The total test points in the 30-2 is around 76 points. 76 points for the 30-2, and the points apart is 6 degrees and 3 degrees from the midline. 3 degrees from the midline. This is the main difference between 30-2 and 30-1. Now, the 30-1 is not available anymore. Most commonly is 30-2 or 24-2 and so forth, so on. For 24-2 central visual field, it is same like the 30-2. However, we omit the peripheral points. As I said that the 30-2 is 76 points. So in the 30-2 and 24-2, we omit the peripheral points. Just we will keep only the nasal points to correspond to the nasal stem. So instead of 76 points, we will have 54 points, only 54 points. Others criteria is the same as 30-2. That is, we have 2 points straddling the vertical and horizontal midlines, and they are 6 degrees apart. 6 degrees apart. So this is 24-2. Instead of 76 points, became a 54 points. Okay, this is another test pattern that's named 10-2. The same, the points are straddling the vertical and horizontal midlines, and it is measuring the central 10 degrees of the retina. So it is more concentrated only on the central 10 degrees. It contains 68 points, so you can understand that this is a more zoom and more magnification of the center of the macula as compared to the 24-2, which contains only 4 spots in the central 10 degree, 12 spots in the central 10 degree. The 10-2 contains 68 points with 2 degrees apart. That one 24-2 is 6 degrees apart. However, in the 10-2 is 2 degrees apart. So this gives you a high resolution for the central 10 degree, useful in cases of advanced glaucoma, as well as in early detection of glaucoma if there is any changes in the central area.
In the next slide, we will show when we use the 10-2 and when we use the 24-2. An important point that I would like to stress and emphasize for all postgraduate students that before they used to say that 10-2 is used for mainly for advanced glaucoma. However, by showing this map, according to the Hood et al. Hypothesis, that the inferior temporal and superior temporal poles of the optic disc are the most vulnerable areas of glaucomatous damage. That's called the macular vulnerability zone. Now you can see this is the inferior part or the inferior pole of the optic disc. This is the inferior temporal part of the optic disc, and this is the most vulnerable part in glaucomatous damage. And similarly here is the superior temporal part. Now, if you look to this map, this is the inferior temporal part of the optic disc. It represents the nerve fiber layers that is locating within the macula, within the central 10 degrees. And however, the superior temporal part of the optic disc, which is also the second most vulnerable part after the inferior temporal, representing nerve fibers that is located outside the 10 degrees. So if we just depends on the 10 and the 24-2, which is not representing the central 10 degrees carefully, so we will miss this finding or these changes in early glaucoma, especially in glaucoma suspects or patients with ocular hypertension. The changes will appear early in this area. So your patient will be missed if you just depend on the 24-2. However, if you do the 10-2, you will pick up the changes that happens in this area. Similarly, this map also show you this is the changes that happens when the inferior temporal part is involved. You can see this area is located within the central 10 degrees. So, and this is the area represented by the superior temporal part, which is also a vulnerable zone, but it is located outside the 10 degrees, but it is within the 24 degree. So what I want to say that there is no harm that in cases of glaucoma suspect and early glaucoma or glaucoma hypertension, ocular hypertension, to do both 24-2 and 10-2. If both are normal, so your patient is stable and you can follow him. However, if you find a normal 24-2, you should do 10-2 to make sure that your patient is stable. You cannot exclude early glaucomatous damage just only by looking to the 24-2. This message should be clear for all of the students or any people interested in a glaucoma. This is very important because in the traditional teaching before, we used to say that 10-2 for advanced cases of glaucoma, but now they are convinced that 10-2 is more magnification of the central part of the macula, which is the place of early changes in glaucoma. Few points about the difference between the 24-2 and 10-2. As we mentioned before, that in 24-2, the central 10 degrees, it contains only 12 test points. However, the 10-2, it contains 68 points. And this difference is very peculiar to the 10-2, make it very sensitive to early detection of glaucoma. So in 10-2, we can pick up early changes in glaucoma, sometimes even before the 24-2. The reason why, because you have tested 68 points, and however here you have only 10 points in the central 10 degrees. And you know, glaucoma commonly start in the central area and the paracentral area. That's why they start thinking of modifying the 24-2 and they incorporate the 24-2 type C. That's adding another 10 points in the central 10 degrees and corresponding to the nerve fiber layer so that it will not miss glaucoma. Another difference between the 10-2 and 24-2 is the glaucoma hemifield test is not applied in the 10-2 because 10-2 is meant mainly for detection of the central area only. However, the design for the glaucoma hemifield test is applied for 24-2 and 30-2 to compare the two hemifields of the upper and lower part of the retina. So if anybody asks you about the difference, this is the difference. The third point is the stimulus size. Usually we use in both the stimulus size number 3 or size 3, Goldman size 3. However, in 10-2, we can use a stimulus size of the size 5, which is bigger. especially in advanced glaucoma. However, commonly we use stimulus size number 3. So 10-2 is high resolution, gives you a high zoom in of the macula, and it is more resolution, has more resolution than the 24-2.
Important point that I would like to emphasize here that, as I mentioned earlier, when we superimpose the 10-2 over the 24-2, we notice that the central 10 degree of the 24-2 contains only 12 points. However, the 10-2 contains the 68 points. And when we make the circle more smaller, if we go to the central 8 degree, there are only 4 points in the central in the 24-2, 4 points. And this make the 10-2 more representative of the macula than the 24-2, and early glaucomatous damage can be easily missed in the 24-2. Now, the newly emerging model of the visual field testing is the 24-2C. You can see here, there is, in this C, it is the same as 24-2, but we add another extra 10 points in the central 10 degrees, but distributed according to the distribution of the nerve fiber. So this is the 24-2C. You can clearly see this appearance. This is glaucoma hemifield test. Now, this glaucoma hemifield test is very useful index used in the perimetry printout because it shows a high specificity and high sensitivity for glaucoma detection. In this test, we compare 5 areas in the upper field of the same eye with the 5 areas in the same eye. This is 5 areas, and this is 5 areas in the same eye. We compare them together. So the result can be either borderline or outside the normal limits, or it can be abnormally high sensitivity or general reduction in the sensitivity. We compare this data with the age-matched normals, and we come with the conclusion this is a normal glaucoma hemifield test or outside the normal limits. So it is very important and very useful to look for it because it has a high sensitivity and high specificity for glaucoma.
Lastly, I will speak a few words about the G pattern visual map that is done in the octopus perimetry, which contains 59 different locations or 59 spots to be examined within the central 30 degree. The central, so this corresponds to the 30-2 field in the Humphrey perimetry. But these locations are distributed according to the distribution of the nerve fibers, and also concentrating or accentuating into the nasal stem. So it is very helpful and useful in detection of glaucoma. So the points are distributed according to the distribution of the nerve fibers and reaching up to the central point up to 2.8 degree of spacing. So it is very useful in early detection of glaucoma.
Again, to remind you here, after we finishing the different test strategies, and we spoke about the different test patterns, now we will come to the third point. That's the interpretation of the perimetry map, starting from each zone, and we will speak about each zone in details.